Hello, and welcome to CPAP for the BLS provider here at Upper Saucon Ambulance Corps. Start the presentation with a case study. You get dispatched to a 70-year-old male patient with breathing problems. He has an increased shortness of breath for 1 day despite the use on his inhalers. He has a history of COPD, hypertension, and diabetes. He's a thin white male, is on home oxygen, breathing through pursed lips, sitting in a tripod position. He takes an albuterol inhaler, Lasix, and aspirin. His vital signs are blood pressure of 180/90, a heart rate of 120, respiratory rate of 30, oxygen saturation is 88% on his home O2. His level of consciousness is alert, and his airway is patent. In the physical exam, you see some perioral cyanosis, no jugular vein distension. Lung sounds show some inspiratory and expiratory wheezing. His extremities have some cyanosis, but there is no pedal edema noted. So for this patient, what are some differential or working diagnoses? A list of things that you may think is wrong with the patient. Well, maybe you think that he has an exacerbation of COPD, perhaps he has a pneumonia or even a bronchitis. So presently, what are some treatments we can do to help this gentleman? One of the more important things is to help with his positioning. When you place him on the stretcher, make sure he's sitting upright. He's already in a tripod position, so facilitate that if possible. You want to provide him with some high flow oxygen. BLS protocols now allow us to assist with his inhaler. And another thing that's important is to contact ALS and make sure that they're on the way. After today, at Upper Saucon, you will be able to utilize CPAP as another treatment to aid this man. So what is CPAP? Well, it's an acronym, and it stands for Continuous Positive Airway Pressure. What does it do? Well, quite simply, it gives continuous positive airway pressure. And we'll talk about what this exactly means and how it helps. First, we'll review some upper airway anatomy. Things that I'd like you to pay attention to in this particular slide is that the nasopharynx and the oropharynx and the laryngopharynx are all combined into the upper airway. Some lower airway anatomy, you'll see that the trachea comes down and splits into two bronchi. The area where it splits is called the carina. Then from where it splits, it goes on to bronchi into smaller bronchi called bronchioles, and they eventually end the bottom of the bronchial tree at the alveoli. The alveoli are small air sacs that have a large capillary bed, and this is where gas exchange takes place. The left lung has 2 lobes, an upper and a lower lobe, and then the right lung has 3 lobes, an upper, middle, and lower lobe. It's a short video about the lungs. It's going to show a bronchoscope, a view of the bronchi and the bronchioles looking down actually from inside of the lungs.
So what you're looking there is where the windpipe divides into 2 major airways. One supplying the left lung, which is where the arrow is, and on the other side you've got the right lung. And as you go down, the airways divide several times until they reach the end of the lung.
A large surface area is needed to exchange gases efficiently. The surface area of the lungs is about the same as a tennis court.
Okay, that last video mentioned the surface area of the lungs being extremely large. If you look at the photo from the beginning of this video, you'll see it's an actual cast taken from a human lung tissue, and you can actually see exactly how much surface area you're dealing with here. That's one thing to take notice. This video is a little bit into the normal respiratory function.
Each lung is made up of a huge network of tiny air passages, and the secret of what the lungs are for lies in the tiny air sacs at the end of each minute tube. The air sacs are called alveoli, but what are they for? Just looking at them gives you a clue. They're surrounded by a network of blood vessels. That's why we breathe, to get oxygen from the air into our blood. Let's move inside an alveolus and take a close look at a single air sac and a single blood vessel. The air we breathe in is only 20% oxygen. The rest, nitrogen and other gases, is not much use to us, so we'll forget it. When we breathe in, there's more oxygen in the alveolus than in the blood vessels, so what happens next? It's called diffusion. Gases always move from areas of high concentration to low concentration. Oxygen molecules dissolve across the thin membrane of the alveolus into the blood vessels. This oxygenated blood returns to the heart and is pumped around the body to the tissues that need it. When you burn any fuel with oxygen, you get waste products. Blood arriving in the lungs has a lot of carbon dioxide in it, but the air inside the alveoli has hardly any. High concentration, low concentration. Carbon dioxide moves in the opposite direction from the blood to the air inside the alveoli. Breathing out removes the carbon dioxide and the whole cycle can repeat.
Okay, so we'll review a little bit more of the normal respiratory function having to do with inspiration and expiration. During a normal inspiration, as you can see on the picture on the left, the diaphragm will descend and it pulls the pleura apart. It's the space in between the lungs and the lung cavity. This produces a negative pressure effect inside the alveoli, the blue circle there. The pressure gradient is created, and this causes air to flow from the outside atmosphere down into your alveoli. When the end of expiration, the diaphragm is moving upwards into the cavity, and this is causing air to leave the alveoli. At the end of the expiration, the pressure in the alveoli is going to be equal to your normal atmospheric pressure. What kind of things can go wrong now that we've seen some of the normal lung functions? What kind of things can go bad? There's quite a few things, and we'll actually go into some of these into detail. First, let's go over some signs of distress with any kind of respiratory problem. You can see tachypnea, which is a fancy word for breathing fast, JVD, which stands for jugular vein distension, tripod position. You may see somebody sitting in a chair leaning forward, using their hands to brace themselves on their knees. You may see retractions or intercostal muscle use, perhaps some grunting or nasal flaring, and you see this commonly more in the pediatric population. Unequal or inadequate chest expansion, skin condition or cyanosis can give you some signs of distress. Tachycardia or bradycardia, air hunger and anxiety, breathing through pursed lips, which is just the body's attempt to try to create a positive pressure in your airway. Wheezing, Rales rhonchi, and stridor are all lung sounds that can show signs of distress. This video is actually just going to be a small review of your lung sounds, and then the next slide we'll go and we'll show you some lung sounds and see if you can correctly guess them.
There are abnormal breath sounds that you should be familiar with. Snoring, caused by partial obstruction of the upper airway, often caused by the tongue. Stridor, a harsh, high-pitched sound heard on inspiration, is common during upper airway obstructions. Croup is an example of an upper airway obstruction commonly found in young children and is usually associated with a seal-like barking cough. Wheezing is generally a whistling sound due to the narrowing of the patient's airways from edema, bronchoconstriction, or foreign body aspiration. Rhonchi is a rattling sound heard in the larger airways caused by excessive mucus. Rales are a bubbling sound heard in the smaller airways, typically when they fill with fluid, commonly encountered with CHF and pulmonary edema.
Okay, we're going to play a succession of lung sounds. I'll give you an opportunity to listen to them and be able to tell what the sound is. Here's your first lung sound. Okay, that lung sound was rhonchi. Once again, rhonchi is the sound of a thick, mucusy sound, usually in the upper airways. Now we'll go on to the second lung sound. Okay, that was the second lung sound. It's a little bit hard to hear, but it was a wheezing. Wheezing's the musical sound that you can hear with inspiration or expiration, or possibly both. Go on to the third lung sound. Okay, that lung sound was stridor. Stridor is an upper airway obstruction. It can be commonly heard with croup or an upper airway obstruction such as a foreign body obstruction. Usually you'll be able to hear this more loudly if you place your stethoscope over the trachea. Move over to the fourth lung sound. Okay, that lung sound was rails. Remember, rails is a thin, watery sounding, usually down in the alveoli. We'll go to this last lung sound. Okay, this last lung sound is a little bit more difficult because it's a combination of two, which is wheezing and rhonchi, and also a little bit of tachypnea, which are fast breathing. If you need extra practice with lung sounds, there's many resources you can find on the internet. Try doing a Google search or a YouTube search for lung sounds. Okay, now we're going to move on to some of the different disease processes. The first one we're going to talk about is congestive heart failure. Congestive heart failure is not actually a disease, but a syndrome that can be brought on upon multiple causes. First one is hypertension, myocardial infarction, cardiomyopathy, which its causes can also include coronary artery disease, a viral infection, chronic alcohol abuse, or diabetes. You could have heart valve problems, arrhythmias, or possible drug hormone imbalances. Those hormone imbalances could be a thyroid imbalance. Other drugs that can cause these is cocaine or methamphetamine use. The chart on the right will show exactly how much heart failure we're dealing with in hospitals, is actually how many hospital discharges in millions. You can see, other than deliveries, heart disease is the most popular thing that you can be discharged in the hospital with in the United States. Some signs and symptoms of CHF include severe shortness of breath and hypoxia. You could also have orthopnea, rales or rhonchi, usually in both sides of the lungs, tachycardia. Your blood pressure can be either very elevated or in an advanced stage it could also be very low. Most likely the person will be coughing a pink frothy type sputum. You will see some jugular vein distension, and it's also important to note that the patient will be non-febrile, means they do not have a fever. You can see from the graphic some of these things that we're talking about that you may see in a person with CHF. This video will go on to talk about how CPAP can help CHF.
CPAP actually is like blowing up a balloon at your birthday party, which all of us have done. If you blow the balloon up and then allow the balloon to blow your lungs up or inflate them and then breathe in and out, this is very much like what the person who is experiencing the benefits of CPAP notices, that it's much easier to let the chest rise. Even in you who have normal work of breathing requirements, it will make it a lot easier to get the air in, and it tends to make it a little more difficult to get the air out. What this essentially does then is to expand the gas volume in the lung, especially in circumstances in which the lung is wet, collapsing, and has what's called a low pulmonary volume. We refer to the static volume of the lung, that is where a person is not making any effort to breathe in or out, as the FRC, the functional residual capacity. And that means you're making no effort to inhale or exhale. In certain conditions, things like heart failure especially, as the water builds up in the lungs, it washes out a chemical called surfactant that allows the lung to stay inflated. When this is washed out, the air sacs collapse, the oxygen falls, the lung becomes very stiff and more difficult to stretch, and the patient notices the desire to breathe rapidly and shallowly, and a desperate feeling ensures. Under standard therapy, we have now found that CPAP is an ideal remedy to correct a lot of the abnormal physiology that's happening here. And the real problem is simple. The body is viewed as a two-chambered heart system. On the right side, we have the venous return that is going through the lungs. It's a very low-pressure system, and because of this, the right heart is very thin, much like a balloon. The left heart is a pressure pump. It has 5 times higher pressures to handle, so it therefore has to thicken, or hypertrophy, if you will, in order to do the job of power pumping. Since heart disease principally involves the left side of the heart, and the right side of the heart is not involved, when there is an issue involving heart failure, the usual reference is that the left heart slows down its pumping ability, the stroke volume, which is how many cc's per squeeze the heart puts out, diminishes, and fluid that is being transported through the lungs by the right heart is no longer allowed to exit into the left heart. The difference builds up in the lungs between the two chambers, and lo and behold, the lung gets stiff, hard to move, and we see the whole downward spiral of congestive heart failure and pulmonary edema. The principal use of CPAP acutely, especially in transport, has been to enable us to rapidly change the physiology of these individuals. When one hauls people around to the emergency rooms, a lot of what we do depends on the time we have between the patient's pickup place, the home, the nursing home, or even out in the community, and the time it takes to transport to the hospital. So acutely, we would like to start reversing the damaged physiology that is life-threatening.
Okay, so to review, how exactly does CPAP help CHF? Well, it increases alveolar ventilation. It helps, the increased pressure helps the gas reach the alveolar level. It also can shunt open the alveoli, kind of like they said in the video, like blowing up a balloon by keeping it expanded without allowing it to collapse. It'll also reduce the effort of breathing, and just by reducing the effort of breathing, it's going to have less demand on the heart. The next disease process we'll talk about is chronic obstructive pulmonary disease, or more commonly referred to as COPD. When you're talking about COPD, you're talking about actually a couple of different diseases that are all kind of lumped into one category. These diseases are emphysema, chronic bronchitis, and asthma. Also, something generally to note is that 90% of your risk factor in getting COPD is cigarette smoking. It's a quick video to review COPD.
Chronic obstructive pulmonary disease kills over 100,000 Americans each year, making it the 4th leading cause of death in the United States. So what exactly is chronic obstructive pulmonary disease?
Actually, chronic obstructive pulmonary disease, or COPD, refers to 2 different diseases of the lung, emphysema and chronic bronchitis. Since emphysema and chronic bronchitis are each usually caused by years of cigarette smoking, afflicted individuals are almost always diagnosed with both at once, hence the umbrella term chronic obstructive pulmonary disease. This combination of diseases can also be caused by years of inhaling a variety of industrial toxins, fumes, and chemicals. Prolonged exposure to air pollution and secondhand smoke, or even a history of childhood lung infections, can also lead to COPD. However, since chronic bronchitis and emphysema affect 2 different parts of the lung, let's take a separate look at each of these diseases. Chronic bronchitis is characterized by an inflammation of the bronchial tubes, which are passageways that branch off from the trachea or windpipe and allow air to enter the lungs. This inflammation causes thick mucus to build up in the tubes, preventing sufficient air from reaching the lungs. Emphysema occurs when the walls between the air sacs and the lungs, known as alveoli, lose their elasticity. This, in turn, causes the air sacs to become fragile and overinflated, leading to an unnatural retention of air within the lungs. The symptoms of COPD tend to depend on which disease is more prominent in an inflicted individual. If emphysema is the predominant disease, the first notable symptom will be a shortness of breath during physical exertion. This will soon be followed by a phlegmatic cough and pursed lip breathing. If chronic bronchitis predominates, a persistent mucus-filled cough will often be the first symptom to appear. This may be accompanied by wheezing, shortness of breath, fatigue, and respiratory or lung infections.